Okay, I'm talking today about not just delirium. Oh, you said these arrows were going to make it go.
Click on the slide.
No?
Now use your arrows.
Okay, so I'm talking today about evaluation and treatment of mental status change, mental health issues that come up in hospice and palliative care. My name is Alice Emery. That's an email you can always reach me at, and there's my cell phone. In this talk, I want to go over mental health, just kind of definition and talk about it a little bit, and I want to talk about reactive or adjustment mood disorders. I want to talk about delirium and agitated delirium. I want to encourage you to look for the underlying causes and also to use antipsychotic medications to treat it. I want to talk a little bit about managing behavior problems in dementia, which is kind of a hot topic. And I want to just give a shout out to the caregivers and remind you about some of their issues in dealing with these mental status changes. So, mental health for adults. I say that the ability to take care of yourself, support yourself, the ability to maintain relations with other people, be cooperative and cordial with your colleagues, have supportive family relationships. These are all signs of good mental health. You play a role of a parent or a spouse. You're able to engage in useful work because you have to have focus, you have to be able to solve problems, you have to be dependable. All these things are important to show that you have a decent level of mental health. You have to be able to balance your leisure activities and your work and avoid self-destructive patterns, and you have to be able to relax and enjoy positive experiences. So I think all these things are signs of good mental health, but it doesn't say that you'll always be free of negative emotions or that you'll never have stress or strain or you'll always be happy, because those things are normal and part of life, to have stress and some negative emotions and some positive emotions. So just to be mentally healthy doesn't mean that you're always going to be happy. And now, the way I like to look at mental health is that it's kind of like a baseline requirement for function. Like, say, here is your mental health. It is almost like a baseline requirement for doing all the things you want to do. You want to be a physician, you have to have basic mental health to be able to do it. And then I think the things that support that are like columns that hold up the building that your mental health is, or the platform. So I think your home is one of these columns. So your home, your habits, your environmental constancy, your work or your useful engagement is one of these columns. What you do every day, your family and your relationships is one of these. Spirituality or your mission, if you don't want to invoke the religious way of looking at it. Spirituality. And then health, your body constancy. So every day you wake up, your body feels good or feels the same as it did yesterday. So all these things I think are important to maintain this platform of mental health that you count on to be there as a backdrop for everything else you want to do for your day. And I think sometimes when we think about our patients, say a young man who's 45 who has just been diagnosed with terrible sarcoma. He's all of a sudden dealing with a big change in his health. And it's all of a sudden it's going to change his ability to work, and it's going to impact his family hugely. So all of a sudden all these columns are very shaky. So our patients are dealing with a lot of stress to their mental stability, and they have to figure out ways to adjust to keep these things intact somehow, and keep functioning. So I think everyone, as they go through their life, is going to have stresses and times when they're having a hard time keeping it together, pretty much. And what they used to call a nervous breakdown is just something like when something terrible happens in someone's life, they can go into a dysphoric mood or negative thoughts, and they can end up with depression. So I'd like to try and work against this stigma of mental illness where some people have mental illness and some people don't, because I think that throughout the life of any particular person, there's going to be different levels of mental and emotional health. And when we see someone who's having depression or anxiety issues, they may be a person who's just gone through a lot lately and so has had their baseline disrupted. There are some people who can go through all kinds of stress and not have trouble with mental health, with anxiety or with depression, and those people are called more resilient. And then there's a lot of interest in finding out what makes those people more resilient. And positive psychology is working on trying to look into factors that can be taught that would increase resiliency in people like soldiers, etc., as they're going out into a stressful situation, or perhaps it would be nice to be able to build resiliency into your high school students before they go to college. Also, there's this idea of thresholds where even if you take mentally healthy people and subject them to a certain amount of stress, they're very likely to have mental illness. For example, soldiers who go into war zones, there's a certain percentage that are going to develop PTSD afterward, and that relates to how much stress there was during the experience. So when you talk about mental health, modern psychology or psychiatry likes to break it down into brain chemicals, and they say there's a balance of brain chemicals. And if you think about the different brain chemicals, and then you think about what that's supposed to be doing in your brain and what we think it's doing, and then you can kind of connect it with the medications that we use for psychiatric illnesses. Dopamine, we know has to do with motivation, with drive, versus low dopamine is associated with kind of like laziness, not motivated. And there's excess dopamine in agitated psychosis. There's excess dopamine in a schizophrenic who's talking and hallucinating and hearing voices. So if you have a situation of excess dopamine, we tend to use the drugs that will decrease dopamine, and things like Haldol, Risperdal decrease dopamine. And a person who has not enough dopamine will have Parkinsonism. So Parkinson's disease is a disease where the neurons that use the dopamine for a neurotransmitter are degenerating. And so if you have a patient who's been given Haldol, they're likely to show signs of Parkinsonism. Hello. Serotonin is another one of the brain chemicals. This one is associated with a secure feeling, important feeling, versus ineffective or outcast kind of sensations. And many drugs increase the serotonin in the brain, including the SSRIs. Oxytocin is a brain chemical that boosts calmness and trust, intimacy versus disconnectedness. They say that a hug or a visit from a pet therapy dog will increase your oxytocin. Also, there's a drug called ecstasy that is supposed to increase oxytocin, and it's called the love drug. Endorphins, we alleviate pain. Those are our internal opiate-like brain chemicals, and they relieve depression and anxiety. So supposedly laughter, dark chocolate, and opioids give you that endorphin hit. GABA is also another brain chemical that is basically inhibitory, decreases the activity of the neurons in general, and it will make you feel more relaxed and happy versus anxious and stressed. So benzodiazepines work through the GABA. Also, gabapentin also does too, but benzodiazepines and alcohol give you that. Okay, so a person with no history of mental health problems may develop symptoms under severe stress or loss. For example, an adjustment disorder after a loss, such as grief, is a kind of short-term depression-like state that people go through normally after they have a loss. So a person who's lost their spouse may have a lot of the same symptoms of depression. but it's considered a situational depression, and usually lasts less than 6 months. There's also another type of PTSD we talked about before. It's an acute stress disorder, but it can last up for years. There's some talk about primary versus secondary depression or anxiety. Most of the time we don't really know which is which. If you've got a person with so-called primary depression, it means that out of the blue they become depressed, versus a secondary depression is they're depressed because they have cancer. So a lot of times our patients, we think of they're having secondary depression because they're dying or whatever, and there's a little bit different treatment protocols for primary versus secondary depression, but basically we don't have any medications that can differentiate the two. So for facility patients, the standard for mental health is a little bit lower. We really just need people in facilities, like say in nursing homes, to be calm and cooperative. We like them to have a neutral emotion, and we want them to be compliant with staff. And palliative care or hospice referrals can result from the inability to maintain calmness or cooperativeness. How many times have we had a referral for a patient just because their behavior's out of control, even though they're not really at end stage dementia? The most common cause of acute on chronic, behavior management issues is dementia, but there also can be acute or subacute issues with behavior and mood that aren't caused by dementia, and in that case there's some sort of medical disturbance in the neuronal functioning. So if you have a patient who has say a cognitive impairment, but all of a sudden they're having a lot of behavior issues and they're having a lot of trouble focusing and functioning, there may be some sort of a physical or organic etiology. Anxiety, just in general, anxiety is a sensation of fear. It should be thought of as either in proportion or out of proportion to the real or actual danger. Has anybody ever had or seen someone have an anxiety attack? Mm-hmm. Yeah? So I talked to my mom one time. She was in the hospital when she was having chest pain, and she told me she had a panic attack. And I said, "What? How did you have a panic attack?" She said, "Well, I was having chest pain, and they told me you have to wait till the morning to see the cardiologist, so don't move, hold completely still." And she said then she had a, quote, panic attack. I'm like, well, that's not a panic attack, that's just anxiety, and it seems like a reasonable response. So I think sometimes anxiety is just a reasonable response to stress. But other times anxiety is beyond what is appropriate, or it's so high that it really needs treatment in itself, a symptom that needs treatment for itself. So if we say anxiety is a fear of a future event, it can be, but it also can be just something that's going on right now. Like, for example, if you're short of breath, there's a lot of, if you've ever been short of breath, it's very anxiety provoking. And so to separate out the anxiety from the shortness of breath is very difficult. And when you have a terminal illness, there's plenty to be anxious about. Normally, for people like us, the future or right now in a healthy person feels very different. For example, right now I feel pretty good, and in the future I hope to have more money, more time, more fun. The future looks good. But for a patient with a terminal illness, things are very different. I had a patient who was an identical twin, and she had multiple myeloma, and she was very anxious. And when you talk to her about why, because she has a painful illness, her legs hurt, her hip hurt, her cancer, she's thinking is damaging her kidneys because she knew that her identical twin sister had multiple myeloma, her kidneys failed, her hips shattered, and her legs had to be amputated because of the fractures in her bones. So this lady, who's then got the same disease that her twin sister had, she has high anxiety. But it's relatively appropriate. It isn't really a mental illness per se. But still, we had to treat her with medication to help with her anxiety. So, medication is not the only way to treat anxiety or panic. There are some other ways to help people through their fears. For example, counseling with our social workers and our chaplains is very helpful. Usually people who are having anxiety or even a panic attack that's not appropriate to the situation still have enough mental clarity to be able to benefit from interpersonal counseling or visits from a soothing professional. They're not generally having hallucinations, delusions. Those things go with psychosis. Severe anxiety can be brought on by medications or by substance withdrawal syndromes. Have you ever seen a patient with alcohol withdrawal? Alcohol withdrawal is a situation of high anxiety, and that's because the alcohol suppresses anxiety, and so when they're in an alcohol withdrawal state, they get to an anxiety state that increases and increases to the point where it's actually dangerous. So to generally talk about delirium, delirium is usually something that happens acutely over hours to days. There's a decreased awareness of your surroundings and your personal state, and there's an impaired ability to attend to things, and a decrease in rational thinking. Confusion is the most simple medical word to explain delirium, and there's usually some kind of medical illness behind it. Now, compared to dementia, delirium happens more acutely. Like if you have a patient who was driving and living alone 2 weeks ago, and now today they're in a nursing home very confused, you won't say that is from dementia, because dementia doesn't progress that fast, right? Usually if you're talking about a new diagnosis of dementia, you can track it back months or even a year or two where people say, oh yeah, she got mixed up on this and he got mixed up on that. So it isn't something that comes on within a week or two, as delirium does. And there can be an increase in purposeless activity level, or increased anxiety and increased restlessness, but not always. So here was the DSM-4 definition of delirium, which I thought was pretty basic. It's a disturbance of consciousness, so reduced clarity of awareness in the environment, reduced ability to focus, sustain, or shift your attention. And then this change happens without having a dementia or other something else that's explaining it, and it develops over a short period of time. And then usually we can find some cause, some physiologic reason or general medical condition that explains the delirium. So here's a case, 89-year-old woman on hospice at home for COPD with dementia. Reportedly she had not slept well Thursday night, then she was up and down all day Friday. Now they're calling the doctor at 1 a.m. on Saturday as she has been not able to sleep, climbing on the table, says the daughter's trying to poison her, won't take her pills, and she's not herself at all. This is just typical for a phone call that you would get in the middle of the night. This is a hyperactive delirium. Here's another case, an alcoholic cirrhosis patient. He's been in the hospital 2 days for a GI bleed. He's having trouble staying awake, his sentences are trailing off, he's not speaking coherently, his ammonia levels increased. So this is a hypoactive delirium. Still delirium, still the confusion, and mostly in medical terms we would use this toxic metabolic encephalopathy, we would call it. So who is at higher risk for delirium? Well, the elderly are. In some studies there's an 80% prevalence of delirium with hospitalization. People with sensory deficits, people with hearing or vision impairment are at higher risk for becoming confused. Pre-existing dementia or cognitive impairment, even if it's not that severe, predisposes a person to become confused in certain situations. Alcohol or substance addiction or withdrawal, of course, is a risk factor for delirium. Previous episodes of delirium. So if you have your grandmother who's doing great, but when she went in the hospital she got confused, the next time she goes in the hospital she's likely to get confused again. Previous episodes help predict a recurrence. And then what we see the most is a dying patient, or patient with basically multi-system organ failure. They often will have confusion, and they may have that psychomotor agitation as well, so the terminal restlessness. I think that people who have poor emotional acceptance of the situation, say they're dying but they really don't want to die for some reason, family discord, lack of trust, or spiritual distress, they think they're going to hell, something like that, they tend to have more trouble relaxing, and they tend to be more agitated as they become confused. So agitation is kind of a separate thing from confusion. Agitation is a psychomotor disturbance with neuronal excitation characterized by marked increase in purposeless motor activity in a patient. It occurs very frequently in the hospice setting and can be isolated, or it can be accompanied by anxiety or delirium. So physical motor restlessness is a kind of agitation. It usually goes with anxiety and delirium, but not always. And something is usually driving it. It's nice to be able to figure out what's causing the agitation. Have you guys ever seen agitation with clear sensorium? Physically agitated person who can't sit still, but still can answer questions and seems clear-headed.
It's like the manic depressive.
Well, a manic person, though, they've got problems with their thinking as well. They want to spend money, they think they're
Well,
important.
grandiose, but they're oriented and
But they
can make sense, answer questions.
They can.
But then when they're on their own, they go off into these.
Yeah,
Little tangents.
so they have some problems with their thinking as well. Well, we saw a lady the other day who had supposedly restless leg syndrome, which had gotten so severe that it was almost like it was a psychomotor disturbance, which she just kept trying to get up, but yet you could talk to her. She says, "No, I'm not uncomfortable. And nothing's really bothering me. I just think I should get up." Another time when that happens is with antipsychotic medication reactions. There's a kind of extrapyramidal reaction called akathisia, where they're agitated physically, they can't sit still, but they're pretty clear mentally. So agitation is often accompanied by loss of control of action and disorganization of thought. And the causes are frequent, things that occur in a terminal illness: metabolic disorders, medication, sepsis associated encephalopathy, pain, and so on. And even external factors can cause agitation, like a person who has dementia and then there's jackhammering outside, that can increase their sense of agitation. And agitation itself can be a dangerous situation. If you've got a patient who's agitated for 3 days, they're probably going to have falls, they're probably going to be dehydrated, they're going to be exhausted, and if they're at home, their family's going to be exhausted. So here's a mnemonic for helping you remember what could cause delirium: drugs, emotions, and that includes mania or depression, low oxygen, infection, retention of urine or feces. This is a common thing in patients on hospice. They keep wanting to get up, but then you find out that they haven't had a bowel movement in a week, and that could be the reason why they can't settle down. Ictal states, supposedly some sort of low-level seizures could be causing agitation. Not so common in our population. Undernutrition. Yeah, I think it's a kind of a given that a lot of our patients are undernourished, but it's kind of rare, I think, that causes agitation just by itself. Metabolic, organ failure, or thyroid, so a person with liver failure or kidney failure for sure has a higher risk of delirium. And then stroke. A stroke by itself can cause confusion. So here's a phone call. Patient is an 87-year-old. She's been on hospice 14 days with debility related to a prior hip fracture and pneumonia. Baseline, she's been able to speak, answer questions, and yesterday she was getting out of bed over and over. Last night she didn't sleep at all till the morning. She was more confused with nonsensical speech, and the family is getting exhausted, and they request a medication to make her sleep. The nurse calls you and says yes, no question. Ativan okay? You can just say yes and go back to sleep. But the real answer is that you need to try and ask about the causes of this change in this patient who has been doing okay and now isn't. So is there something that was changed? For example, did we just start a medication a few days ago? Is she in pain? Has she been having regular bowel movements? Has she been urinating okay? Is she hypoxemic? She has pneumonia, maybe her oxygen level is low. So it's very fruitful to go through these with the nurses, because often when you get a phone call with a question, can we start Ativan, it's just easier to say, okay, 1 milligram Q4 PRN or whatever, without saying, okay, let's just hold on a minute. What's going on here? Let's see if we can figure something out. Maybe this patient hasn't been able to urinate for 12 hours. Maybe she hasn't had a bowel movement in a week. Maybe she's can have a O2 sat of 70 and you could put some oxygen on. So there, even medication changes, often, an on-call person doesn't think about that, but a medication change can cause problems a few days after it happens. So fixable causes of agitation or delirium, as we said, fecal impaction, urinary retention, pain, low oxygen, and infection. And these are all common in hospice patients, and often our patients often have reasons to have encephalopathy, and so all of these things are easily overlooked. So what would you do if you think it might be pain? Well, I think it would be reasonable to try some pain medication. If you have a patient who's otherwise doing well, but they're becoming confused and having a kind of agitated delirium, then I think pain medication is worth a try. Hypoxemia, that's pretty easy. Start oxygen. Infection, if they don't appear to have an infection, it still may be worth testing for a UTI because they don't always have symptoms that localize the infection, but yet they can have quite a bit of derangement from a UTI. And we had a patient just the other day who came on hospice because of hallucinations. She stopped eating. She was having pain. She was in terrible shape. She went to the ER several times. She got on hospice, and the hospice nurse said, well, would you like some tests run? And they said, no, we don't want anything else done. She's already been to the ER. She goes, well, how about a urinalysis? Okay, so she had a urinalysis that showed a UTI. She got treatment, and 5 days later, she's awake and doing fine and saying, why am I in this dementia unit? You know?
This one at Freedom Village,
Yeah.
Yeah.
So she turned right around. Now she's eating like a horse, and you're gonna have to give her a job at the dementia unit because she has to stay there till the end of the month.
Take care of the other.
So really, in an elderly patient, a UTI can cause a huge derangement. And in her case, it may have been that she had some back pain, and then she got some pain medicine that made things a little confused for her, and then after a couple ER visits, she got, I don't know exactly where the UTI came in, but she definitely turned around a lot just from that simple intervention. So in addition to these easy causes, there are some more complicated things that can happen and having to do with medications. And this is where it gets a little harder to remember. You've got to remember to check for these things, or at least go over the med list in a person who you're trying to understand what's going on. How can insulin cause you to be confused?
I have a question.
Okay. How does digoxin cause you to be confused?
Isn't there like a primary effect and arrhythmia?
Yeah, the arrhythmia is not the confusing part. What about Decadron? What does Decadron do that can cause agitation, agitated psychosis type situation, right? Have you ever given someone too much Decadron and then the next day you hear they've got a speeding ticket and they want to go to Las Vegas and they're driving their family crazy? Yeah, so Decadron or steroids can also cause an agitated kind of state. Alcohol intoxication, we all know, can cause you to be confused, but also alcohol withdrawal. Benzodiazepines, a toxic effect, too much benzos can cause confusion and sedation, and also withdrawal can cause anxiety and agitation. The one that we tend to forget is the adverse reaction to benzodiazepines. About 5% of people theoretically will have a paradoxical effect to benzodiazepines. That means instead of the nice, calm, relaxing feeling that we expect, it will actually cause physical restlessness and neuroexcitation. So they'll become agitated and restless. And it's sometimes hard to sort that out. You know, when you're looking back at the story of a patient who's started on Ativan and become more restless, it's hard to tell if the Ativan is causing the restlessness. It really is. Like if you say, well, she's been on that for a year and every time she takes it, it helped up until this last week and all of a sudden she's getting restless, then it's not the Ativan, right? But if she started the Ativan about the same time as the restlessness started, it's hard to tell whether the Ativan actually has caused the crescendo of this problem or not. And so if you've got a patient who's been started on Ativan and is getting more and more restless, one thing you can do is switch to a different class of drugs. Don't just switch to a different benzodiazepine, like from Ativan to Xanax, because that really won't help. If they're having a reaction to one, they'll most likely have it to some degree to the other ones as well. So I would say switching to Haldol then is a good way to get a break from the Ativan and make sure that that isn't what's driving the whole process. Seizures can be potentiated when a person is having a paradoxical reaction to benzodiazepine. Also, seizures can happen when they're having a withdrawal from benzodiazepines. They can have disinhibition, aggression, and it can be mistaken for mania or schizophrenia. And you just have to stop the offending serotonin. And with the neuroleptic malignant syndrome, they usually have, sometimes they have just been stopped, their Sinemet has just been stopped, or sometimes it's with a neuroleptic or antipsychotic medication that this occurs. So those two are interesting. The main way to tell them apart, if you're thinking, oh, this is either serotonin syndrome or neuroleptic malignant syndrome, I'm not sure which one. The neuroleptic malignant syndrome has a lead pipe rigidity and hyporeflexia, versus the serotonin syndrome has hyperreflexia with clonus, or with excess reflexes. And then another thing to just mention is akathisia and dystonia. So we know that Ativan can cause restlessness, motor restlessness, but also your Haldol that we use so frequently can cause a motor restlessness. This akathisia is a word that's talking about the motor restlessness that can occur. It's an extrapyramidal motor effect, a side effect of primarily the first generation antipsychotic medications like Thorazine, Haldol. Not so much seen with the second generation like Risperdal and Seroquel that we use frequently. So you all has anyone seen akathisia? Yeah? So the person will be moving, usually moving their feet and moving their body, but they won't necessarily be as mentally ill as they were previously. It's sometimes so hard to sort out because if they're still, thinking, if their thinking is still confused, they may not be able to give you the answers to explain that they just feel uncomfortable and need to keep moving. But that is a complicating factor when we're trying to treat someone for restlessness or agitation, and then you have two medications that we use frequently, Ativan and Haldol, and both of them can also cause worsening of restless agitation. And also dystonias, we don't see those very often, but they're quickly treatable with just a shot of Benadryl. So dystonias are just a basic thing to remember if you're using antipsychotic medications. And then narcotic excess. I'm not sure if that even should be in here, but we know that there's such a thing as restlessness, agitation, and twitchiness that can come from use of opioids. Like if you've got someone else on Roxanol, they can get twitchy and restless just because of that. It's not quite the same as these other ones. All right, so Mr. L was a hospice patient with colon cancer. He was on Reglan, Senna, Tramadol, and a fentanyl patch. You started Celexa, and then he became restless, sweaty, and weak. On day 2, he had nausea and vomiting, fever, and some jerking movements. The nurse says, oh, the jerking movements, that's weird. Something's going on. What is going on?
Like with serotonin syndrome.
Okay, serotonin syndrome, that's easy, right? If only we could just remember that more often when we're out in the world. It's common to have medications that increase serotonin. All these, not the Senna, but the Reglan, Tramadol, fentanyl, and Celexa all increase serotonin. Other causes of toxic metabolic encephalopathy or agitated delirium are things that are not so easy to fix, like electrolyte imbalances, fatty acids, proteins, or amino acids, things like that that are high or low, glucose, too high, too low, circulatory disturbances, and organ failures. We can't necessarily fix all those things. We can try to prevent them by monitoring electrolytes and good nursing care and early recognition, but most of the time in hospice patients, as they get sicker and sicker, they're going to have more and more organ dysfunction and even neurologic dysfunction. So it's nice to try and prevent it, but it cannot always be prevented. So how can we evaluate the severity of an agitated delirium? I would say mild would be that there's disordered thinking with some paranoia or hallucinations leading to medication refusal or care refusal. So a person who's worried that the nurses are trying to poison them and doesn't want to take her pills. Moderate is that they also have a distressed affect with psychomotor agitation causing a safety risk. So now they think the nurses are trying to poison them and they're trying to get out the door. And then severe would be distressed affect, motor agitation, and aggression or attempts to harm self or others. In this one, they're not only trying to get out the door, but they're fighting and punching people and trying to hurt someone. So mild, moderate, severe will give you different levels of what you want to use to treat the patient and how quickly you need to get ahead of it. So whenever they talk about the management of delirium, they always say that you should use non-medication management first. So you want to make sure that the room is calm, that the roommate is not aggravating, that there's a reasonable level of stimulation. You want to be especially careful for veterans, because a veteran who's become confused can easily become agitated if there are loud noises or other environmental stimuli that mimic a war zone. So for veterans, they tend to be very careful with that. For safety purposes, they use sitters, restraints, or physical limits as needed in keeping with the degree of safety risk. So there are a lot of rules about the use of restraints. Even the beds with the mattress like this is now considered a restraint, so the skilled facilities are having a hard time using any kind of physical restraints. But one-on-one sitters are very expensive, and so management of toxic metabolic encephalopathy, if it can't be soothed quickly, will require medications. And mostly we want to use the antipsychotics. The antipsychotics were developed beginning back in the 50s with Thorazine. Actually, Thorazine was a breakthrough in the care of schizophrenia because they didn't have anything before that really helped. But Thorazine had many serious side effects. It's very sedating. And then Haldol, which was again in the same class, is a favorite of hospice and palliative care because it's so easy to titrate, but it's still a first generation antipsychotic. And then the atypical antipsychotics have been developed more recently, and they have less of the extrapyramidal motor effects. It can be sedating also. Seroquel, for example, is one of the most sedating. So just how to manage an agitated delirium case. If the person is mildly agitated and delirious, you might start a daily oral antipsychotic plus or minus a benzodiazepine. If you're in a skilled nursing facility, they usually want to start with a benzodiazepine, like a 0.5 milligram Ativan twice a day, PRN, something like that. It's not all that effective, but at least it helps change a person who's got an agitated delirium to a hypoactive delirium sometimes. That's kind of the hope. It doesn't really clear the head that much. Moderate delirium, you're going to need to use an oral loading dose and then a daily antipsychotic plus or minus a benzodiazepine. So if you've got a patient who's, say they've got renal failure, they're getting worse and worse, and now they're starting to hallucinate and having situations where they're refusing care or refusing to take their pills and things, you may want to just go ahead and put them on some Haldol, like 2 milligrams now and then 0.5 Q8 continuously, and then plus or minus a PRN Ativan. For severe encephalopathy, I think that's the kind of people that come in the ER. What do they give them in the ER, Todd?
Ativan and Haldol.
Ativan and Haldol, quick and high dose right now, and followed by probably some ongoing scheduled doses of both. They can use IV or IM. Supposedly you can use oral also and get pretty good results. I saw one study where they're using oral antipsychotic and benzos in the ER, and it worked just as well. But for violent resistant patients, we definitely want to give something quick and high dose at the beginning. So Haldol is the kind of drug that once you get it loaded, it's a long-acting drug. So you give a big loading dose, and then you can give a lower dose for continuing effect. And you're going to need to titrate. For milder patients, it's nice to use Seroquel or Risperdal in low doses. For patients who have a history of Parkinson-like illness, like Lewy body dementia or Parkinson's, we would go with the Seroquel or the Risperdal because of the lower incidence of extrapyramidal effects.
And if I can, just a word
Yes.
dosing.
Go ahead.
When I kind of started my training coming out of the ER background, I was kind of surprised at the higher doses that we would use in hospice care, particularly with a lot of the narcotics, this kind of a thing. I would, in the ER, would consider giving somebody a Vicodin 6-pack a pretty good narcotic gift. And of course, that's just a tiny drop in the bucket compared to what we often give our hospice patients. But things can also be a little bit reversed, so the use of Haldol is one of them. You know, we often start our patients at hospice on 0.5 milligrams of Haldol, whereas coming from an ER background, the minimum dose I might give somebody would be 5 milligrams, so 10 times the initial dose, and it was not uncommon to give somebody 10 milligrams of Haldol. And so sometimes kind of knowing those different environments, you can safely kind of start to expand your dosing options to you. And so certainly in my patients now, I don't have any problem giving them a loading dose of oral Haldol 5 milligrams and saying if things aren't better in about an hour, give them another 5 milligrams if we need to. That's okay, that's safe to do.
Right, so a person who gets a aggressive loading regimen, like say they have 5 milligrams now and repeat again, or 2 milligrams every half hour, and,
Right.
you know, up to a certain point, then can probably be put on a lower scheduled maintenance dose. And then this Ativan, Klonopin, Valium, Xanax, these are all commonly used benzodiazepines. They have, each one has a little bit different feel to it, and a little different half-life, and even maybe a little different marketing of what their niche is. Klonopin has been marketed for seizures because it's kind of like the long-acting version of a benzodiazepine. Xanax has been marketed for panic attacks because it's a short-acting version. And you know the medications that are used for inducing sleep, the hypnotics, are in this category as well. And they're usually a quick onset and quick, a short half-life medication that's used for hypnotics. And then Versed, just to talk a little bit about Versed, that is a very short-acting benzodiazepine, which can be used IV or sub-Q. It can be used intranasally too. We had a patient who had seizures, and she would see something, and she knew she was going to seize, so she had a little bottle of intranasal Versed that she could squeeze when she felt a seizure coming on. Versed is very, very helpful for when you get into a situation with an agitated delirium where you've really tried everything and you're not really able to manage it and to keep the patient calm. Like say you had him on Ativan and Haldol, and then you went to phenobarb, which would be another step up. And then still the family's having to give all these meds every 3 hours, every 2 hours, and this patient is still not comfortable. That's where we bring in the sub-Q Versed. And if you have a baseline plus a bolus, it's very, very calming and very helpful, and you can adjust the level of consciousness very easily, and the family isn't having to give all these medications. Yeah, so this is what I just said. There's also nasal spray and sublingual versions of Versed. Then there are a couple other things you can use for anxiety or delirium. Phenobarb is available as a suppository and also can be used IM, so you can use 60 or 120 milligrams of that. But it may only last a short time, and so you're going to need to have a follow-up plan. Buspar is something that's used by mostly non-palliative care physicians for anxiety when they're trying to not give benzodiazepine. So it's pretty mild, but it's a slight sedative. And Depakote is also used sometimes for agitation, or especially for behavioral problems in dementia when they're trying to use something other than a antipsychotic. Do you have other ideas, Dr. Mulder, of something that you used in the olden days for a sedative, a general sedative, besides phenobarb, besides antipsychotics?
No, anything that I've ever used have already been on your list. You know, benzodiazepines, Haldol, and we also have engaged the Q1 hour, we call it crisis dosing, and we'll escalate the dose and do it every hour until we get somebody calm. And you're right about the Haldol has such a wide therapeutic window. I've had people with Huntington's on as much as 80, 90 milligrams a day of Haldol, and as long as you're not having your psychomotor side effects, you can keep cranking it up there. But phenobarb, we like that. We do higher doses of the phenobarb. It comes in it's a weird dose, like 92.4
Right.
milligram tablet, and so we'll give 1, 2, or 3 of those, and with good success. And,
You can pretty much sedate anybody with phenobarb, enough
absolutely,
phenobarb.
if you give them enough phenobarb. And the thing about phenobarb is that when you look at the, well, we talked about the PDR last week, and nobody knows that anymore. But you know, if you look at the information on the phenobarb, you load them. If you're using a procedure, you load the grams of it, not milligrams, but grams of it. And so it's again a very wide therapeutic window. And if you give enough, you can sedate them with very little side effect impact other than just hangover. You know, they won't wake up.
Right, or
for
the fact
hours.
that while they're asleep, they're not eating and drinking, and
Right.
so that, yeah.
Also, we used the thing called Secanol induction.
Secanol.
Oh yeah,
That's
that
another-
goes back a long
Another
way.
The woman had been in labor all day
Yeah.
and was exhausted. It was 11 o'clock. The doctor was exhausted too. Give her a couple hundred of Secanol and she'd sleep beautifully for 4 hours, wake up in active labor and have a baby.
Now
so-
they just give epidurals instead.
Yeah.
So it's similar. We used to use. I think back again, old timey stuff. We used to use chlorohydrate a lot.
Right, yeah, I thought you were gonna, that's what I was
It's,
kind of
it's,
hoping to
it's
get at.
especially with the kids. You know, we used and we used to use that all the time pre-procedure. If they're and it wouldn't have to be a major procedure. You know.
So just a general sedative,
Yep,
chlorohydrate.
Chlorohydrate. Yep.
Yeah, we really don't see that anymore, I don't think. Now they use propofol if they want just to sedate someone temporarily for a short procedure. So behavioral problems in dementia, that really it probably could be a whole talk in itself because it's a hot topic. The hospice and palliative care people definitely will be asked to assist in the management of behavioral issues in chronic dementia patients. And there really should be, it shouldn't just be behavior problem, then you give a medication. It should be a whole interdisciplinary assessment of the situation and given some thought to the reinforcers and the causes of the behavior. And the people who are looking into this, they really want us to focus less and less on giving a medication to solve every problem and more on the interpersonal and behavioral treatment of the patient. So if we just separated it into different levels of how much behavior problem you have. Verbal non-aggressive, an example of that would be calling out, help me, help me, help me all day. What do you want? Nothing. Go away, help me, help me. Okay, a verbal aggressive, what would be a verbal aggressive? Saying, come here, I'm gonna punch you, or I don't know. Verbal aggressive. Physical non-aggressive would be something like wandering, going and getting in bed with other patients, or stealing things, or hoarding things. And then physical aggressive would be like if you're resisting care and then you punch someone or you squeeze someone's arm and hurt them. So I think when they talk about using medications, they don't want to use antipsychotic medications for any of these except number 4, physical aggressive. If you have someone who's just wandering or someone who's just calling out, we don't want to give them a medication with potentially increased mortality and a lot of negative side effects just for something that is kind of annoying. So behavioral intervention should be the mainstay. Off-label use of antipsychotic medications is used to manage behavior problems in dementia, but good nursing facilities are really trying to decrease the use of antipsychotics in nursing facilities, and that is not a bad thing. The periodic dose reductions that they do are a good thing because you certainly don't want someone put on heavy sedating doses of antipsychotics for something that happened at a certain point in time and then just leaving them on that forever. So quality of life measures and changes in the way people are treated are going to make a big difference for how many patients need to be on these medications.
Alex,
Yes.
just a quick word about held on the nursing homes because it's very common to get if you're recommending that, the nursing home will say, well, we can't give that, or it's against the law, and it's just this misinterpretation of regulations. Mm-hmm. And the genesis of that goes back to the day in which we were chemically sedating patients to make them behaviorally compliant, essentially chemically restraining folks, and they said that's wrong, and you're correct, it is wrong, and they do, it's good to restrict that. However, they absolutely can give it. The issue is that there's a burden of documentation as to what has failed and why they're giving that, and to be able to do more frequent visits and document the follow-up on that. And so that's really, to get around that and to get around the onus of having to do the documentation and explain to their supervisors why they're giving Haldol. They just tell the doctors, we can't give it here.
Not only
That's
that,
not true.
now, there are online databases that show what percentage of people are using antipsychotics in their facility.
Right.
So they feel that it will affect their brand if their facility is known to be a heavy utilizer of antipsychotic medications.
Right.
So they really act like a single patient on antipsychotic medications is a black mark on their marketing or on their brand. So it's not only just documentation now. It's really hard to get any. Definitely not Haldol. You really can't. You're not going to be able to use Haldol in the nursing facilities these days. But you could use Risperdal or you could use Seroquel if you have good documentation that you've got an aggressive safety risk related to it that has not been amenable to behavior modification. So first you have to document the behavior that is dangerous, and then you have to document what you tried to help the behavior, and then you may use something like Risperdal or Seroquel, and then you have to document that it improved. And then
Exactly.
eventually you'll have to document that you attempted to decrease the dose. So it's just
And it's
A
key to
lot
have
of
a good
roadblocks.
relationship with the facility to be able to
Yeah.
say, we're not trying to bully you into this, and we're not trying to be antagonistic about it. Trying to help you out, trying to help our patient out, and so long as they have a good working relationship with you and a trusting relationship, and you're
you're willing to jump through the
thoughtful about it
hoops.
as you talk to them. Anytime I start people on an antipsychotic in a nursing facility, I usually will preface it by saying, I know it's gonna cause you guys a lot of big headache here, but I actually think it's the right thing to do, and here's why. And usually you'll find somebody reasonable on the other end who will help you with it, and sometimes you won't. Sometimes you'll go back into corporate policy, because some of our facilities are corporately owned, and they just have a blanket policy against it, but it's a headache to use, but there's nothing legal
There's
about
nothing
it.
regulatory or illegal, it's
It's
a
not
burden on
illegal,
them.
it's just that
But same
it
thing's true of
looks bad to
narcotics,
have
too,
too many
so-
patients on antipsychotics, so they really are trying to keep it down. And also, well, there's just a lot of reasons why they don't want to use chemical restraints on patients with dementia. And there are some studies showing it doesn't help. So it helps for certain things. It helps for aggression, just sort of out of the blue. It doesn't help so much for care refusal. It helps for paranoia and hallucinations. But if you've got patients with Lewy body dementia, they're going to be especially sensitive to the extrapyramidal effects. So they really recommend that be maybe a specialist who manages that, like say a psychiatrist or a neurologist, rather than us. So if you have a person with Parkinson's or Lewy body dementia, you need to be extra careful giving them doses of Haldol, or and probably you should use Seroquel in smaller doses and focus more on other ways of managing them. And we have a form that we can fill out that risks and benefits and behavior recommendations and things like that, so to put in the chart, and they ask for that pretty often. Okay, so acute mental status changes. I just wanted to mention, don't forget the caregivers. If you've got patients at home who have had delirium for 3 or 4 days, that family is going to be completely exhausted and overwhelmed. They can't sleep, they got to watch the person all the time, they may not understand. If your wife says, you're trying to poison me, the husband may be feeling grief over that, They're not used to seeing people go crazy like we're used to seeing. So there's a stigma about it, there's a lack of understanding. They might, I've heard people say, Dad went crazy at the end of his life. And I think, gosh, that's a terrible thing to think, that your dad went crazy at the end of his life. He just got confused because he was sick, and so you need to speak to them. So not only talk to what's causing this and what's going on, but ask, how's the family doing? How are they holding up? Is it just one person, one elderly wife trying to manage this situation? You probably need to call in the kids, get the daughter to come stay or something like that. So don't forget to ask about the caregivers when there's an acute mental status change that's affecting a home patient. And so I want to say that mental status changes are part of a long downward trajectory of disease. So in our patients, we're likely to see that here and there. It may come and go. And we want to try to prevent it. We want to treat the underlying causes if possible. And we want to address the psychological or spiritual distress that might be contributing to it. And for our patients who are terminal, we're going to put them probably on some antipsychotic and benzodiazepine medications, and if possible, we're just going to continue that schedule on. And I just want to remind you to think about the caregivers. And that's the end of my talk.
Wonderful. Thanks so much.
Thank you.
Thank you.